Today's ECG video training is on how to recognize left bundle branch block. It's very important to be able to recognize left bundle branch block because it does affect your protocols, it affects the patient's symptoms, the patient's outcome. It's a very important skill to have. First, I want to look at the conduction system in the heart, and we'll talk about normal conduction first so that you can easily recognize abnormal conduction. So with normal conduction, as the impulse comes out of the AV node, this is normal, it should land in the bundle of His and then come down the common bundle and then simultaneously go down both bundle branches. Okay, the goal here is to get the impulse, the electricity, down both bundle branches into the ventricles simultaneously, into the Purkinje fibers, and the electrical impulse will reach as many cells as possible and depolarize them all simultaneously. If that happens, then your right ventricle will depolarize, the septal wall will depolarize, and the free wall of the left ventricle, the anterior wall, the posterior wall, all of that pretty close to simultaneously. And that gives us a really good snappy heartbeat. It gives us a good cardiac output because all the blood gets squeezed out at once. And we'll get rid of that, and we'll talk about abnormal. Now with normal, the outcome of all that good snappy conduction, fast conduction, is a narrow QRS, and that's very ideal. That's what we want, narrow QRS. With abnormal, one of the bundle branches isn't working. In this case, we're talking about left bundle branch block. So I'm just going to put a little roadblock right across the main part of the left bundle. So we don't know why that roadblock is there in this demonstration, but it could be a heart attack, an MI has killed the tissue. It could be that a surgeon has cut it. It could be old age and it's just worn out. But something has happened, even a drug, we don't know. Something has happened, though, that has blocked the ability of the left bundle to conduct electricity. So now what's going to happen is the impulse will come out of the AV node, down the common bundle, and easily go into the right bundle branch and easily depolarize the right ventricle. Okay, now the problem is the left ventricle has not gotten the message, but it was promised that it would be depolarized by the all or none principle. The all or none principle says that if we depolarize even one cell in either one of the ventricles, that impulse will spread to all the other cells and they'll all be depolarized. It's like a domino effect. Now, in this case, the right ventricle was depolarized very quickly through the fast racetrack conduction system. But the left bundle branch is blocked, so the racetrack is closed. We can't go the fast way. The only way we can go now is the slow way. So all the cells in the right ventricle here that are depolarized are going to send the message to the cells next to them, and they're going to send the message to the cells next to them, and eventually the entire left ventricle will depolarize, and it also will contract. The problem is it took longer, and that's not good. When you take longer to depolarize the ventricles, what you end up with is a wide QRS. And a wide QRS is not a good thing. It actually lowers cardiac output by up to 15, even 20% in some people. Now, some people can tolerate 15 or 20%. You yourself can probably tolerate that and not feel too bad, too sick, but a lot of your patients can't tolerate 15%. So that's definitely not a good thing for them. We don't want a wide QRS. Okay, so I'm going to draw in these arrows just to show the direction of that depolarization wave. It's a little different than normal. Normal depolarization goes down and to the left, but in this case, the left ventricle has now been depolarized by the right ventricle. The right ventricle got the message first, sent the wave over, and now the left ventricle is getting it later. If you were over here in V1, on the V1 side of the heart, and you were looking at that lead, what you would see in this case, I'll do a P wave here, what you would see would be a negative QRS. That's because you're over on the right side of the patient, and the main wave of depolarization, which is going through the left ventricle, is going away from you. So you get a negative V1. Now a normal V1 is negative, but this isn't normal, this is wide. On the patient's left side, the right side of the screen, we go over to V6, and V6 is going to see the opposite of that. V6 is now going to see an upright QRS And again, upright's normal for V6, but this isn't normal because it's wide. So this is how we recognize left bundle branch block, that V1 is negative but wide, and V6 is positive but wide. And I'll show you on an ECG. Okay, here we have a nice example of a very typical left bundle branch block. And we're going to look for the criteria so that we can always recognize left bundle branch block. Good news is your machine's actually pretty good at recognizing left bundle branch block, and often up in the diagnostic area of the ECG, which I've removed here, but often it will say left bundle branch block and get it right. But don't count on that all the time. Always be able to read it yourself so you can be sure. Okay, so how do we recognize left bundle branch block? First, foremost, most important, we have to have a wide QRS. Anything over 0.12 seconds, or anything 0.12 or over even, is considered wide. And this one is 0.154 seconds, so it easily meets that criteria. In this case, you can see it with your eye too. It's very, very clear to see. So that's the first criteria, wide QRS. The second criteria that we need to meet is this must be a supraventricular rhythm. And what that means is it's not ventricular. So ventricular rhythms would be V-tach, obviously, idioventricular, accelerated idioventricular, even paced rhythms if the ventricles are being paced. Those would produce wide complexes, but they're not bundle branch block because they're not supraventricular. Anything with a P wave that's associated with the QRS is a supraventricular rhythm. That, of course, includes normal sinus rhythm or all the sinus rhythms, atrial rhythms, junctional rhythms. Those are all supraventricular. So one criteria for having any bundle branch block, left bundle branch block in this case, is supraventricular rhythm. There are a couple of supraventricular rhythms you need to remember that don't have P waves. P waves are nice, they make it easy, but junctional rhythms don't always have P waves, and atrial fib doesn't have P waves. Also, if the rate gets really fast, you may not see the P waves because they're buried in the T. Those situations can make it much harder to recognize left bundle branch block, because in order to recognize left bundle branch block, you have to meet the criteria. So the two we've talked about so far are the wide QRS and the supraventricular rhythm. And the supraventricular rhythm, in this case, we can recognize by seeing P waves. And by the way, remember that the 3 channels you use to run your 12 lead are simultaneously run. So each channel is a rhythm strip from left to right. It's a continuous strip, it doesn't stop. But also each beat has another, it's shown 3 times, let's put it that way. It's shown in a vertical line 3 times in 3 different views, but it's the same heartbeat. So if you're having trouble seeing P waves, like right here where this artifact is, I don't see P waves too well. But if I look right below it, right down here, there's a P wave. And since that happened at the same moment in time, I know the patient has P waves. So don't be afraid to use your multiple leads. That's one of the values of 12 lead, is you can look all around, and some leads are better than others for looking at certain things. So look for your P waves. Now we know we've met criteria number 2. Criteria number 3 for left bundle branch block is what I showed you in the graphic with the heart and the conduction system. V1 should have a negative QRS, should point down, and V6 should have an upright QRS, points up. Now remember that in a normal ECG, V1 is down and V6 is up. What makes this abnormal? The wide QRS. That's the only difference. Now, if you haven't done a 12 lead yet and you want to just get an idea if you're looking at a bundle branch block, you really need the 12 lead to be absolutely sure. But just on your rhythm strips, if you have a lead 1 on your rhythm strip that you do initially, lead 1 is very helpful. Leads 2 and 3 are not so helpful, but lead 1 over here can help you meet the criteria. And lead 1 is kind of a copy of V6. They're located in a pretty similar part of the location on the body. Lead 1 is on the left arm, and lead V6 is right under the left arm in the mid-axillary line. So they usually look like twins. And you see here, in this ECG, they do look a lot alike. So if I were doing a quick poor man's screening for left bundle branch block, I would do it this way. I would say the QRS is wide, I see P wave, not too well in V1, or lead 1, but I see it in lead 2. And lead 1 is upright, so I think this is left bundle branch block, and I would be right. Okay, so back over this one more time for the criteria, and then we'll look at one more. This ECG has obviously wide QRS, 0.15. That tells me there's probably a conduction delay of some type through the ventricles. They have P waves, so they have a supraventricular rhythm that's running into a conduction delay. And because the QRS is wide and negative in V1, positive in V6, and also positive in lead 1, I can make the diagnosis of left bundle branch block. In a separate talk, we'll talk about the significance of left bundle branch block and how it affects your treatment protocols and how it affects your patient. Now we're going to look at one more example and see if we can meet criteria. Well, the first thing I notice about this ECG is that it's very fast. And when I look a little closer, I realize it's also very irregular. Not just a little bit, but very irregular. I don't see P waves, but I know the one rhythm that's always irregularly irregular and has no P waves is atrial fibrillation. So this meets the criteria for atrial fibrillation. The one thing I notice about this that isn't typical of atrial fibrillation is that the QRSs are very wide. On first glance, you might think this is VTAC. But it's not VTAC because VTAC is rarely, if ever, this irregular. There may be some irregularities, but not like this. This is irregularly irregular. Without P waves, it can only be atrial fib. So what can happen to atrial fib to make it wide? Well, atrial fib is a supraventricular rhythm, so that impulse as it comes down through the AV node has to travel on the bundle branches. If something's wrong on one of the bundle branches, it can encounter a bundle branch block. So in this case, we're going to go through the criteria for left bundle branch block. We see the QRS is wide, it's 0.15. Definitely meets criteria. The supraventricular rhythm criteria is met if you're brave and you trust that your knowledge that an irregularly irregular rhythm without P waves is atrial fib. That meets the criteria for supraventricular rhythm. And then the last criteria is V1 is negative and V6 is positive. And also, even though lead 1 isn't very tall, it's also positive. So this is atrial fibrillation with left bundle branch block. Now, before we go, I do want to mention one thing. When you encounter a wide complex, a wide QRS tachycardia in the field, if your patient is very unstable, you may not have the time or feel that you have the time to stop and really go through this analysis the way I just did with the 3 criteria. You do have a protocol for wide complex tachycardia. It's the same thing as VTAC. Always consider a wide complex tachycardia to be VTAC until you prove otherwise. So let's say this patient looks very bad. First glance, we think it's VTAC. We actually know now that that would be wrong. It's atrial fib with left bundle branch block. But let's say in the heat of the moment, we see that to us it looks like VTAC and the patient looks really bad. The blood pressure's low, the perfusion is bad, the patient seems to be going down the hill pretty quickly. We need to do something. If we just drop back to our VTAC protocol, this patient will be safe and will be okay, because if they're very unstable, we have to shock them. Now, I know a lot of people don't want to shock atrial fib. There is a slight possibility of throwing a clot and having an embolus, but if your patient is truly unstable and about to die and has no perfusion, you've got to do something. And electrical conversion works for atrial fib and for VTAC, so you don't have to take the time to make that differential diagnosis. If the patient's very stable, then you would want to treat this as atrial fib, and if they're stable, you probably don't even have to treat it, just get them to the hospital. But if you do make the mistake of thinking that it's a VTAC and they're very stable, and you give amiodarone, which is the protocol for wide complex tachycardia that's stable, you haven't hurt the patient, because amiodarone is actually a pretty good drug for atrial fib. And the doctors in the hospital can pick up where you left off. So even though this can be a little difficult to diagnose because there are no P waves. If you make a mistake and call it VTAC, it wouldn't be the worst mistake in the world. The patient would still do okay. You would still do a good job. The important thing is to remember that atrial fib is irregularly irregular, and VTAC, it really isn't. We have polymorphic VTAC, which is irregular like a torsades, but you can see by looking at this, it's not one of those. So the only thing it can be is atrial fib, and what widens the QRS is left bundle branch block.